and certainly a warm welcome to our speaker, Alex Muggy, from who's Director and Deputy Chief Health Information Officer within the Office of Burden Reduction and Health Informatics. Alex has been with CMS almost 11 years, I believe, and prior to that was with a health plan. So again, to be able to put in use a lot of working at a health plan, and then now all of the work that she's been doing at CMS. We really want to offer a warm welcome to Alex. So without further ado, Alex, I'll turn the program over to you.
Thank you, and thanks everyone for joining today and for having us on your call. Hopefully you can all see the slides on my screen that I'm sharing. Today we wanted to talk through the interoperability and prior authorization proposed rule, which many of you may have seen. It was released last December, and it talks about some of the implications of what's happening with that rule. Some of you may have also seen a version of a final rule, which was posted in January on the cms.gov website. The rule has since been taken down and is under review with the new administration, but we can talk through a little bit more of that after we walk through an overview of some of the proposals from the proposed rule. So just before I even get started on the proposals, I wanted to give a little context on this rule and where we came from, why we decided to focus on prior authorization. As many of you know, last May, CMS finalized the CMS Interoperability and Patient Access final rule. And in that rule, we focused on patient access and improving healthcare data flow between patients and payers. And we also had some policies for hospitals in terms of conditions of participation, all focused on increasing data flow in healthcare. So that rule was heavily focused on patient access and care coordination. This second interoperability rule that we've put out is focused on enhancing some of those policies from the Rule 1, and it's also focused on reducing the burden of prior authorization. We have here at CMS and throughout the healthcare industry heard for many years the challenges of prior authorization and the challenges that the prior authorization process pose for providers in terms of the time and effort that it takes to submit prior authorization requests on behalf of their patients. And we've also heard many pain points on the side of patients who, in seeking healthcare, don't have a lot of transparency into the prior authorization process and really struggle with understanding how this influences their access to their care. So this second rule is heavily focused on reducing those burdens of prior authorization with the intent of streamlining the process for providers and increasing transparency for the patient. So I'm going to go and jump into the proposed policies. So in the first interoperability rule, the Interoperability and Patient Access Final Rule, we finalized a policy that required all CMS regulated payers to implement a FHIR-based patient access API. In the first rule, we finalized that API would include clinical data as well as claims and encounter information and formulary data for patients to access through a third-party application of their choosing. In this proposed rule, we proposed that the impacted payers of this rule would add to that API any information about a patient's pending and active prior authorization decisions. And also, we would require that the API would be updated to use several implementation guides that we have previously encouraged for the building and implementation of this API, but we did not previously require. So those implementation guides are for claims and encounter data. That would be the HL7 FHIR Consumer Directed Payer Data Exchange, or Karen for Blue Button implementation guide. For the clinical data and USCDI data, we proposed the HL7 FHIR Da Vinci Payer Data Exchange, or PDEX implementation guide. And for the formulary data, we proposed the HL7 Fire Da Vinci Payer
Alex,
Data Exchange, or PDEX.
I didn't want to interrupt, but I wanted you to maybe adjust your to a full screen. I think we're still in presenters mode. Yeah.
Oh, that is not showing on my screen.
Okay, so
Let me
figure it.
see.
If you maybe go down to.
I do apologize. I don't want you looking at the wrong.
If you go to display settings and click on the down arrow, then you should be able to switch it.
Okay, hold on. We had this going right for the whole time we were in the prep meeting, but not as soon as you add everybody else. How about now?
Yes, great. Thank you, Alex.
All right.
I'm sorry for interrupting.
Well, no worries. The only downside of this is that I will tell you I can't see any notes that I had, but I can go without notes. But for some reason, it is hiding it on my screen. So, but I don't think that's a problem. So apologies for the technical difficulties here. But what I wanted to highlight is that we proposed those 3 IGs for the patient access API and expanded it to include the prior authorization data so that patients would have more transparency into the data about prior authorizations. What is not shown on the slide is that we also proposed an implementation guide to support the provider directory API, which was also finalized in the first interoperability rule. So finalize the API itself in interoperability rule number 1. In this interoperability rule, we proposed an implementation guide that would support payers in implementing that provider directory API. So moving on to our next API. So we also proposed in this rule a new API that is the provider access API. And this is based on what CMS, or Medicare fee-for-service, is already working to implement. We call it our data at the point of care API. And this API allows payers to share claims and encounter data directly with providers through an API so that the provider can access that data directly in their EHRs. So in this proposed rule, we proposed that this data would include the claims and encounter data, as well as the pending and active prior authorization decisions and formulary data for patients. So a clinician can ask for this data from the payer and would have access to it in their EHRs. This API would be implemented on January 1, 2023. And again, this would be for providers to access that data on behalf of their patients. We also proposed, as part of this API, now I've lost my place, I'm so sorry. I was counting on my notes for a second. Oh, we proposed the same implementation guides for this API that we had proposed for the patient access API. So these would be nearly identical APIs, but with different intended audience for the information. For the payer-to-payer API, we, in the first interoperability rule, we proposed a policy whereby payers would exchange data with one another when a patient moves from one health plan to another. So I, as a patient moving from one payer to the next over an enrollment period, could request from my previous payer that my data come with me to the new payer. And that way I could build my full health record with my new payer. So over year, I would accumulate that data, bringing my entire healthcare record with me from one payer to the next. We did not, however, propose or require the use of an API for that payer-to-payer data exchange. In this proposed rule, we are proposing that payers would build an API, a FHIR-based API, to share that data from one payer to the next, using the similar IGs that we use for the patient access and provider access APIs. This would help to streamline some of that data exchange process and would get that data formatted into the FHIR-based format so that payers could easily receive a data from another payer and then go on to share it with the patient and with a provider through the other APIs that I've already mentioned. We also proposed as part of this policy that the payers would share this data at the time of enrollment. So instead of a patient having to request that their data come with them when they move from one payer to the next, it would actually flow with them at the time of enrollment. So when they're in that enrollment process, as they're changing from one payer to the next, they'd have the option to, by providing certain information to their new payer, the payer would automatically be able to go and get the data and bring it forward. So thereby sort of streamlining the data flow that happens and taking some of the burden off the patient to make that request. As part of this policy, we had a discussion in the proposed rule and sought comment on how and whether payers should leverage information about prior authorization decisions that come from a previous payer. So understanding that payers would be sending those prior authorization decisions from one to the next, what would be the role of the receiving payer when they receive that information about a prior authorization decision? We understand that each payer has their own criteria for prior authorization, their own services. Like one payer may require prior authorization for a service, another may not. So we were not proposing, we did not make any proposals to require that the new payer accept the previous payer's determination, but we did seek comment on what would be the best use of that data, or how might payers take advantage of that data, with the idea that if a new payer receiving the data did decide to keep that prior authorization decision in place for the patient, it could reduce the burden that a provider has, in that they would not have to submit a new prior authorization request, and it could streamline the continuity of care for a patient, in that they would not have to request a new prior authorization and potentially suffer any lapse in services by going to a new payer. So that was just an area we wanted to highlight as a place where we did seek comment. In terms of the standards of the implementation guides that I've referenced throughout this presentation, the Office of the National Coordinator, or ONC, did propose to adopt these implementation specifications under their authority, which therefore makes these standards available for all of HHS and government to use for various projects, and in a sense finalizes these implementation guides as part of our regulation, but using their authority, which is a bit broader in terms of the health IT standards. So in this way, CMS and ONC work together to ensure that we are finalizing these standards and carrying them forward for implementation. We also proposed 2 APIs that are more specific to the actual process of prior authorization. So with the first 3 APIs I've discussed on the call today, the patient access, provider access, and payer-to-payer APIs, I really refer to those as like the access APIs, or ways to share information that's already been gathered and processed, and making that available, or making it that more transparent to the end user. These prior authorization APIs promote more the processes of prior authorization and help to streamline those processes. So, so digging into it to explain a little bit more what I mean here, we proposed a document requirement lookup service, or DRLS API. This API would enable a clinician to go directly into their EHR, look up the requirements for a prior authorization, and access those requirements directly from their EHR. So in the current world, and a lot of the frustration that we have heard from providers, is that each payer has different requirements, and they house them in different, in their own websites, or in different places within their website, those requirements for the different items and services that require prior authorization. We understand that for providers to locate those requirements can be a considerable burden and time-consuming challenge for them. This API would, in a sense, eliminate that step by allowing their EHR to directly access those requirements. So the API would from the EHR would ping the payer to say, are there requirements for prior authorization requirements for this particular item or service? And the API would respond yes or no, and the EHR could say, if yes, what are those requirements, and then those would be sent back directly to the EHR. So again, just really streamlining and reducing the burden that is required for providers to find these requirements. Then the second piece of this is the Prior Authorization Support API, or PAS API. This API would enable a provider to actually send and receive prior authorization requests and responses directly from their EHR. So they would be able to take that data they received from the DRLS API, populate some of the requirements there, and actually submit their prior authorization request and receive the response directly in the EHR. And potentially in real time, depending on how the payer has this implemented, which could be a considerable time savings and significantly reduced burden for providers submitting these requests. Now, going to this next slide, I wanted to show a diagram of how this actually works, because many of you out there who are familiar with prior authorization transactions may be asking, what about HIPAA? HIPAA transaction standards. The prior authorization transaction is one of the HIPAA transaction standards, and HIPAA currently requires the use of the X12-278 standard for prior authorization requests. So how would we use the FHIR standard to implement the APIs that I discussed on the previous slide? This diagram sort of shows how the X12-278 sits in the middle of the FHIR transaction. So you can see on both the left and right-hand sides of the screen, we have essentially the FHIR bookends here that include the coverage requirements discovery implementation guide, and also and the documentation templates and coverage rules implementation guides. Those two guides that are listed in the top of those blue boxes support the DRLS API, and then the lower box, the yellow prior authorization support implementation guide, that supports the PAS API. So these requirements would be both on the EHR and on the payer side to kind of bookend this prior authorization transaction, with the X12-278 still between those two FHIR servers, and therefore staying compliant with the HIPAA transaction standards with the X12-278. So we've got a lot of questions about this in the rule, and wanted to make that as clear as possible for folks. So including this diagram, and hopefully this is helpful. This is definitely an area that we want to make sure is clear. The X12-278 is still the transaction for prior authorization requests. So moving to this next slide, we understand that the challenges of prior authorization cannot be solved simply with technology solutions and APIs. I wish they could. It would be a great place if all of the challenges in healthcare could be solved with just some electronic transactions and technology. However, we understand there are other process challenges to prior authorization that are not going to be solved by the use of these electronic standards. So we also included in the proposed rule several policies related to more of the process, or several guardrails around the process for prior authorization. So one of the things that we proposed is that all payers would need to include a denial reason anytime they deny a prior authorization request. So not just when the prior authorization request is sent electronically, but regardless of how it's submitted, the payer would need to send a denial reason when denying a prior authorization request. And this is so that providers have more information and can determine next steps. Do they resubmit the prior authorization with more information? Do they need to follow a different process, or do they need to work with their patient on determining a new course of treatment? By having a denial reason, they have more insight into what are the next steps to do with this request. We also proposed shorter timeframes for prior authorization. So in the rule, we did propose, we understand that different payers have different timeframes for prior authorization, but to streamline this and to reduce it down to the lowest timeframe that we found available, we had proposed 72 hours for urgent requests and 7 calendar days for standard prior authorization requests. I will say this is a point that we got quite a few comments on during the comment period, and we understand that folks were asking for us to be even more aggressive in this space. Some folks asked for instantaneous turnaround, and we did see many requests for 24 hours for urgent requests and 48 hours for standard requests. So this was a very interesting point in that we were asked to be more aggressive in this space, but what was proposed was the 72 hours and 7 calendar days. Then finally here we have, we had proposed that certain prior authorization metrics be put in place on that the payers would report on their website certain metrics about their performance around prior authorization. So for example, the percent of prior authorization requests that were approved or denied, or that were ultimately approved after an appeal. This is to give more transparency upfront to patients and providers that are working with a particular payer, for them to understand what how a particular payer operates and what their standards and their metrics are around prior authorization approvals in the process, and give a little more transparency in that regard. So we also included in the proposed rule several RFIs. I know the comment period is closed for this rule, and there's no longer an opportunity at this point to comment on these RFIs, but I did want to just quickly walk through them because a lot of these RFIs were born out of information or comments that we heard from the first interoperability rule, or that we've heard from working with folks in industry. So just to highlight a little bit of the RFI feedback that we were looking for, we understand from the first interoperability rule that there's a strong desire for patients and providers to be able to control the data that is shared. They want to be able to share data, but they may not in every case want to share a whole patient record. So we did see comments on what mechanisms are available and on how patients and providers should be able to control the sharing of health information. We had an RFI on behavioral health providers and information and how to support the electronic exchange for behavioral health information. We also included an RFI that sort of expands on the prior authorization proposals of this rule and sought comment on how we can better encourage or require the use of prior authorization, electronic prior authorization, in our provider community. So would it, for example, would it be appropriate to make a requirement in the conditions of participation for hospitals if they were required to use electronic prior authorization? Or what are ways to encourage clinicians to do the same? We also had an RFI on reducing the use of fax machines for healthcare data exchange. We've had a lot of conversation about the use of fax machines and whether and how they should be replaced in healthcare. So there were some questions about that. And then finally, we had an RFI on the adoption of standards related to social risk data or social determinants data, and what standards are available to collect that data, and whether and how we can work to implement some of those standards in healthcare. So lots of rich content here, lots of things for folks to comment on. I will say again that the comment period for this rule is closed. And just to address the elephant in the room, we did produce the final rule, as I mentioned, and that was posted on the CMS website in mid-January. Unfortunately, the rule, though it was sent to the Federal Register, was not formally published in the Federal Register, and therefore, when the change of administration took place, any rules that were pending at the Federal Register were put on hold, and this rule was part of that. So it has since been removed from the CMS website, and we are awaiting further direction on what will happen with that rule next. So with that, I think I will just stop talking at you and open it up for your questions. So I'll turn it back over to Samantha.
Thank you so much, Alex. We've got a lot of questions already being sent in, so we'll get started with those. The current version of the final rule applies to Medicaid, CHIP, and QHPs. Would there be a new rule applying to Medicare Advantage in the horizon?
That is a question that we received quite a bit through the comment period, definitely, and I should have just addressed that up front. So yes, this rule did not apply to Medicare Advantage, but it did apply to the CMS, the other CMS regulated payers. Moving forward, since we don't know what will happen with the final rule that had already been produced, I will say, anything could happen from here. And one of the options is to revisit the policies as a whole to include Medicare Advantage, or there's another option that there may be another Medicare Advantage rule in the future. And unfortunately, we don't know, so I can't give you a straight answer, but I will say that there was definitely public interest in including Medicare Advantage in these proposals.
Thanks, Alex. Next question, can you clarify the patient consent requirements for the provider access APIs? The final rule was somewhat contradictory and inconsistent in this area.
Okay, yes, definitely. So for the provider access API, what we had proposed was that patients may opt in to the provider access API. So what that would mean would be, if it was an opt-in policy, the patients would need to work with their providers to provide, to essentially request or opt in to their providers receiving that data. However, under HIPAA and the access for patients and payers, since they're both HIPAA covered entities and they would be sharing the data for the purposes of treatment, payment, or operations. Under HIPAA, this really by default could be a data exchange that can happen without the patient opting in. So in the final rule, I think we had received many comments that folks preferred sort of an opt-out option as opposed to the opt-in. And so by not finalizing the opt-in option, we would be saying that it is by default an opt-out. So I know that sounds contradictory, but it sort of makes sense. But so per HIPAA as a default option, this data would be shared under the treatment, payment, operations provisions of HIPAA, and the data would be able to flow between payers and providers without the patient opting in. If we had finalized our policy of it being an opt-in, that would be different. Hope that helps.
Thank you so much. So many more questions rolling in. Okay, this one is somewhat long, so feel free to ask me to repeat any part of it. Our watcher says it is likely that there will be newer versions of the standards being referenced in the current version of the final rule by the time payers are required to comply with the requirements. How will these newer versions be taken into account?
Okay, so that's a great question. And what we have in place today, this was actually finalized in the first interoperability rule and still applies here, is a process called the Standards Versioning Advancement process, or the SVAP process. And this is actually something that ONC finalized in their rule. We point to their rule in a couple of places in the first interoperability rule. The Standards Versioning Advancement process allows for impacted entities to upgrade to a newer version of the standard as long as they remain compliant with the requirements of the proposed rule. So for example, if we're talking about the patient access API and payers implement the patient access API using the implementation guides that we discussed in that slide, and then a new version comes out, and we finalized the versions that are in the rule, new version comes out later, the payer can move to that new version, but they have to make sure that they're not breaking the connection for anyone that was already accessing the patient access API. So essentially ensuring some backwards compatibility there and still meeting the requirements of the rule while also moving forward with the new standards. So this is an area that agree that we have received many questions about and will continue to communicate with you all about to help make that more clear. Thank you for the question.
Next up, the metrics in the final rule were loosened to allow payers to report similar information that they may already be collecting. Are there any specifics as to how closely aligned to the proposed metrics this collected plan information needs to be?
So there is not. What we finalized in the rule was that if the payers are, and when I say we finalized, what we put in a document called the final rule on the website, but which has not been formally finalized, we'll call it the January 15th document. What we put in the January 15th document was that payers, instead of collecting new data to report on their website, thereby adding burden to payers to collect that data, that if they have metrics similar to what we had proposed, they could use that data instead. So we essentially said you can use the metrics that we proposed, or you can come up with your own, if you already have your own metrics, report those. Now, those metrics would certainly need to be, in the spirit of the proposal, and would need to provide some transparency on the prior authorization process. But if they had metrics that better reflected their operations and their metrics around prior authorization, that they would be allowed to do that.
Thank you. Next question. Are there any rules or guidelines around standard value sets for prior authorization denials?
So that is not currently through CMS. We did not specify anything in the final rule or in the proposed rule. We didn't propose anything specific or have any guidance on the final. We understand that there is some work in play currently that would help with that, but that's certainly an area that seems like it's more under development, and in the meantime would be up to the payers to implement.
Has there been any discussion of reopening the comment process once the rule is unfrozen, given the short comment period that overlapped the holidays and how quickly those comments were synthesized into a final rule?
I don't know what the next steps will be for the rule, but anything is possible. I would say at this point, we're awaiting further guidance from our, hopefully our new administrator, who will be joining us shortly.
What is the rationalization for requiring this for Medicaid MCOs, CHIP, and CHIP MCOs, and not for Medicaid fee-for-service or Medicare? What about Blue Cross Blue Shield or commercial payers?
Okay, so there are lots of parts to that question. So, so the rule was proposed for Medicaid fee-for-service, CHIP fee-for-service, Medicaid and CHIP managed care, and also for the qualified health plans in the federally facilitated exchanges. So it did include fee-for-service. It did not include Medicare Advantage. We did mention in the proposed rule and final rule that that we would be looking at Medicare Advantage for future rulemaking. I think, the part that's unclear is how we would proceed with that at this point. Again, whether that is an entirely separate rule, whether the policies would be the same, I can't speak to that piece, but we did highlight that we would be looking at Medicare, including Medicare Advantage in future rulemaking. And then as for commercial plans, they are not under the authorities of CMS, so that would have to go through a separate process for rulemaking. However, we do note that for many of the parent organizations that are included in these rules, they have multiple lines of business. So many of them are not just Medicaid managed care, or not just, for a future rule, it would not just be, Medicare Advantage or just QHPs. So for those payers, there's nothing in the rule that restricts them from offering these same benefits in terms of APIs or using these same processes for their other lines of business. And we would imagine that most payers would choose to implement these same rules to their other lines of business as well. So that would hit a lot of the commercial market, but if we were to do something more formal around the commercial market, that would be an entirely separate type of rulemaking process that would involve other agencies.
Thanks, Alex.
I hope I hit all parts of that question. Thanks.
You went in. We certainly appreciate it. We just have a few more questions before we let you off the hook here. Are payers required to offer opt-out, or is that only via normal HIPAA processes? Also, is it granular or global?
So for opt-out specifically, when I was speaking about the opt-out, that was for the provider access API. So typically with treatment, payment, and operations, there are certain things, particularly around payment, that there has to be certain data exchanged between the entities for those services to take place. So I can't speak to the opt-out sort of globally, but in terms of the policy that we had in this proposed rule for provider access, the provider access API, because this would be considered under that treatment, payment, and operations, but it is the sharing of data that's not for, specifically for payment purposes. I believe the patients always have the ability to opt out. I would need to follow up more specifically on how that would work. But or I'm sorry, like on whether they can always opt out or not. But that is something that we can follow up on if the requester would like.
Thanks, Alex. Next question. Do you anticipate that the final rule will be published will be substantially similar to the final rule that was pulled? Will the direction be basically the same?
I don't know, and I'm sorry, I don't have any information to help answer that question.
Thank you. Another one, how do you see second opinions working if you're allowing automatic data transfer to all providers who may have a scheduled appointment with a patient?
So I might need a little follow-up on this one. If the requester has more information they can put into the chat. But if you're asking second opinions in terms of, in terms of the providers having access to the data. So a provider could have access to a patient's data if they have an established relationship or if they can demonstrate that they have an upcoming appointment for a patient. So if the question is, in the vein of a patient's going for a second opinion, would that provider have access to the first opinion? It would depend on what data the payer already has in regards to the first opinion. I'm not sure I'm helpfully answering this question, so I'm going to pause there, and then if there's a follow-up question, I'd be happy to answer that.
There wasn't a follow-up question, but we do have another one. One more before I let you off the hook. So sorry, you're being so patient with us, and we really appreciate it.
No, these are great questions. Thank you.
Are there any considerations for delaying the 7/1 date for the patient API?
So the July 1st date that's from the first rule, and I believe you're talking about the patient access API. And in the first rule, we finalized the January 1st implementation date, and we did allow for 6 months of enforcement discretion, which pushed the date then to July 1st. We have not heard any further discussions or had any further conversations on postponing that implementation, which is certainly coming up right around the corner. So, but we're encouraging and working with folks to make sure that everyone has the resources to implement. So if anybody has follow-up questions on that, me or my team, we're happy to help in any way that we can to make sure that everyone's successful in meeting that date.
Thank you so much, Alex. And just to let everybody know, we are being flooded with questions and we appreciate them so much. And even if we aren't able to get to them live, we will be following up with everybody with more information to all of the wonderful questions that have been asked. Alex, I know you have a hard stop. So are there any more information that you would like to share with us or thoughts just reflecting on the questions that have been asked thus far?
Well, I again want to just thank everyone. You all are incredibly supportive and helpful, and we always appreciate the questions that you ask because it gives us more direction on, what guidance may be needed. So we're always open to receiving the questions and would love to, hear your thoughts as well. If there are follow-up questions, we're certainly happy to follow up with you all at WEDI directly, or, we also have a help desk email box that is on our web. You go to cms.gov, and if you look for interoperability, our site will come up pretty quickly there, and our website our email box is listed on that website. I should have put a slide with that on here, and I apologize. I didn't realize it wasn't included in this set of slides. But we're happy to answer questions. We appreciate all of your support in helping us to implement these policies and your support for the policies. So please let us know if there's anything that we can do to help answer more questions, and we'll always be here to answer your questions. So thank you. And
Alex,
as soon as we hear an update on the final rule, we will certainly let everyone know.
Sure. And Alex, just let me add my thanks on behalf of WEDI for we know what it's like to juggle all of the challenges in one's day, and we appreciate you moving things around to accommodate this webinar, and we will follow up with comments that are in the chat box. We will be getting those to you and maybe coordinating some responses. So on behalf of Weedy, thank you for taking time out of your schedule to do this webinar for us.
Of course. Thank you so much. All right. Take care, everyone.
All right. Thanks everyone for joining us, and we appreciate your participation and your questions. Thanks again.